You may have heard the phrase that there are no certainties in life other than death and taxes. And while we're not going to discuss taxes by any means, we're certainly going to discuss death in the sense that pretty much everybody at some point will experience death. And in the medical field, we call it cardiorespiratory arrest or cardiac arrest. Even if it's from a traumatic cause or something that didn't initiate in the heart, eventually the heart will stop beating. And that is how we define cardiac arrest. As a paramedic, you're going to learn some redundancies throughout your career about cardiac arrest over and over and again. You're going to have to recertify in BLS and ACLS and PALS, and all of these different courses that you're going to do are going to reiterate a lot of the same points. How to manage a cardiac arrest patient. So we're going to talk about managing the adult cardiac arrest patient. And most patients with cardiac arrest have evidence of prior heart disease. That's the leading cause of medical death or preventable death. It can also occur from electrocution, drowning, trauma, drug overdose, asthma, or anaphylaxis. Basically, anything that kills you can cause cardiac arrest. There's possibly no warning before the event. You've heard of sudden unexplained death syndrome. That's like the adult version of SIDS, basically. It's kind of a general phrase, and it covers things like Brugada syndrome, long QT syndrome, and it happens in young adults. Specifically, it could happen in young athletes, young male athletes. It's very common, and they'll go down suddenly with no explanation. Cardiac arrest management requires an orderly, systematic approach that is rehearsed repeatedly in a team setting. And the reason it needs to be systematic and universal is so everybody on the team kind of knows what their role is and, what they should be doing and what everyone else is doing, because that's really the only chance the patient has to survive a cardiac arrest, is that you have that well-oiled machine in place ready to revive them. Of course, without your equipment, you're pretty useless as a paramedic, right? All of the advanced procedures that a paramedic provides are dependent on equipment or advanced life support equipment, such as a defibrillator, your portable oxygen cylinder, of course, airway management equipment, including an intubation kit, your IV equipment, and your drug box. Your overall goal as you approach a cardiac arrest patient is going to be to gain return of spontaneous circulation and, even more importantly, the preservation of neurologic function. You can get ROSC, or that return of spontaneous circulation where the patient regains a pulse, on anybody that doesn't necessarily have brain function. But to have that neurologic function following a cardiac arrest is huge. When we look at survival rates, you may see a large number, like 70% of cardiac arrest patients receive ROSC. And that sounds great, except that doesn't mean that they have any quality of life. So what we care about is the patients that walk out of the hospital, those neurologically intact patients that are going to lead a life beyond that cardiac arrest. Again, you're going to begin emergency medical care immediately upon discovering pulselessness, and that's really important. And that's why it's so important to get out and do, your public health campaigns, to get citizens involved and to teach them how to do CPR, to have EMD in place. So bystander CPR is initiated through dispatch instructions. And all of those things that are done before the paramedic arrives on scene are really going to be the determinant factors on this patient's chance of survival. There are certainly times when you wouldn't even initiate a resuscitation attempt, such as if it places you at risk. If the call comes in that somebody was shot and they're in cardiac arrest, well, you're not going to go on scene until you know that the shooter is killed, captured, or contained, right? You don't want to put yourself at risk, because then you could become part of the problem and not part of the solution. Also, if there are obvious clinical signs of irreversible death, that would include your rigor mortis, your livor mortis, your tissue decompensation, maybe traumatic injuries like a decapitation or something like that. Obviously, you're not going to try to resuscitate those patients that are beyond the point of survivability. Okay, and And if that's a crime scene, think in the back of your mind, maybe we want to maintain this crime scene and not even touch the person if they look, like they've been dead for a while. Also, if there's a valid advance directive, like a DNRO, a physician order for life-sustaining treatment, form indicating that resuscitation is not desired, we know should be yellow with your original signatures, and all these signatures should be on there, so you can carry out that DNR. And that's really the patient's last wishes, is they don't want to be put on life-sustaining measures. Usually this is a terminally ill person or a very elderly person that has this advance directive, and you wouldn't want to provide treatment, of course, if that's not what they wanted. Also, you may not be doing mechanical CPR, but still trying to resuscitate somebody, and I should mention that. There's something called an LVAD, and that's a left ventricular assist device. And some of them require that you don't do chest compressions because you could actually cause more injury or harm. Some of them, you won't even feel a pulse on the patient and they'll be alive. So a lot of times we call this a chemical code, where we'll just provide your medication resuscitative efforts, and it might even have some sort of hand pump in the case of an event where the mechanical device fails, the LVAD fails. So keep that in mind, that there are these outside the box, outside the norm situations where you would withhold CPR. So of course we're going to review some of the things that you already know to be true from the American Heart Association courses and your BLS course. You're going to proceed with CPR as follows. If the bystanders have delivered uninterrupted chest compressions before you got there, and you think it's pretty good CPR, right? Or if the arrest is witnessed by you or other EMS personnel, you're just going to proceed with a rhythm analysis and shock if necessary, right? If compressions have not been provided, or if the arrest was not witnessed by EMS personnel, then start with chest compressions. And you're going to want to get your full 2 minutes of compressions before you analyze the rhythm. And the reason for that is we want a primed pump. Shocking an empty heart, so to speak, and a poorly perfused heart is not going to work as well as when you defibrillate a heart that has been perfused and has had CPR for about 2 minutes. In addition to providing CPR, you want to maintain you're providing high-quality CPR. This is a big push from the American Heart Association to provide CPR with a rate between 100 to 120. They found that the maximal improvement in patients within those rates, they used to just say greater than 100, and you'd have people that were pushing upwards of 200 beats per minute. Well, if you know how the heart works, you know that you're providing that much of a stroke volume at 200 beats per minute. So that 100 to 120 beats per minute is truly ideal. Compressions of the chest to a depth of at least 2 inches, you want to make sure you're getting blood out of that heart, right? So pushing down about 2 inches in an adult patient is going to help you do that. And you want to make sure you have full chest recoil with every compression. And the way that I teach to do that is, if this is the chest, whenever you put your hand, let's say this is your arm, and that's your hand, bring your palm up off of the chest every time you come up. So you might keep the tips of your fingers in place so you don't lose your position, but raise the palm of your hand every time you come up to allow full chest recoil, because chest recoil is just as important as the chest compression. Okay, keep that in mind. You want to allow the heart to fill so you can then push that blood out of the heart. Minimal interruption of compressions is also super important. You basically build up your cerebral perfusion with each compression until you get to optimal cerebral perfusion provided by manual CPR. And the second you stop, it comes all the way back down to that starting point again. And so you really want to maintain that optimal perfusion as much as possible by limiting and minimizing interruptions and compressions. So during the peri-shock pause, where you're going to be analyzing the rhythm, you want to have your monitor pre-charged, ready to deliver an energy. Anything you can do to shorten that pause is going to improve your patient's survivability. And also make sure you're providing adequate ventilations. This is more important if it's a primary respiratory arrest or your longer arrests, because your initial adult cardiac arrest patient actually has some oxygen reserves that they're perfusing, and you can even have some passive ventilation occurring. But as you work a primary respiratory arrest, a pediatric arrest, or even you're longer into the arrest, you got to really make sure you're giving this great adequate ventilations. So you have 4 possible presenting cardiac arrest rhythms. Pulseless ventricular tachycardia. That's kind of a weird one for me because what makes them pulseless? Certainly, obviously, we know you're not able to palpate a pulse, but the reason we treat this differently than patients with a pulse is simply out of the ease of making the guideline universal. You provide synchronized cardioversion to VTAC when they have a pulse, but you provide asynchronous defibrillation when they don't have a pulse. And the only reason we do that is so you don't have to remember the different treatments. But it is just as effective in your pulseless VTAC as it is in a pulse-style VTAC, so keep that in mind. Of course, your pulseless VTAC and pulseless VFib patients are treated exactly the same, and your asystole and your PEA patients are treated the same. So pulseless VTAC is an organized, wide, complex tachycardia. Pulseless VFib is just kind of a chaotic, and it could appear coarse, it could appear fine. Your newer onset VFib looks a lot like torsades. It'll be this wide, kind of coarse pattern, and then it eventually will get down to what you're used to seeing. Asystole, of course, we know is a flat line. And you can have what's called ventricular asystole or ventricular standstill, where you still have P waves, but you have no QRSs. That is essentially the same thing. And then PEA, while technically pulseless VTAC, pulseless VFib are both types of PEA, because the general phrasing is pulseless electrical activity, we don't count those when we're talking about PEA as far as the algorithm is concerned. PEA is not a rhythm, so you could have a normal sinus rhythm that is a PEA. That's not very common, but that could happen. Typically, you see something like an agonal rhythm or an idioventricular rhythm with a PEA. Of course, we have some key points to remember. If defibrillation is indicated, then the provider giving chest compressions should continue while a second rescuer charges the defibrillator. That's what I was mentioning before, is even if it's not indicated, because you have to stop to look at the rhythm. So before you do that pause, about 15 seconds before you pause, or do your switch, right, of compressors, because that all happens at the same time, charge up that monitor. Even if your last rhythm was asystole, charge it up. Because that way, if it happens to be a VFib arrest, when you do analyze, you don't have to wait and start compressions again and charge the monitor. You can just shock right then and there, and then switch compressors and get back to CPR. Of course, when you pause, you're going to clear the patient to deliver a shock, but that shouldn't worry you too much. With the new biphasic monitors, they've done tests, and no provider at 200 joules biphasic, while compressions are in place with gloved hands, has ever had any ill effect due to a patient being defibrillated while they were touching them. So they actually may, in the future, move towards defibrillation CPR, where you don't even stop. Because with the see-through technology, that you can actually see the rhythm during compressions, and with knowing the very limited risk of touching a patient while they're being defibrillated, it only makes sense that it would optimize the patient outcome by providing compressions during defibrillation. Now, don't go doing that now. That's not yet the protocol or the guideline anywhere. But that is something to keep in mind that may occur. So you're going to pause, deliver the shock after clearing the patient, and then resume chest compressions immediately without pausing for a rhythm or pulse check. Now, when we clear the patient, we used to say, I'm clear, you're clear, we're all clear, and then shock. And that was because we had such a fear of shocking our partner. Now, just announce one time very loudly and assertively, clear. And again, this is because we want to limit that peri-shock pause and get back on the chest. So after your 2 minutes or your 5 cycles of CPR, this is where our pause occurs. This is where we'll call it the switch happens, because you should switch compressors. You should quickly analyze your rhythm and shock if necessary, because you're going to have the monitor pre-charged already, just like we spoke about. If there's a rhythm other than VFib or VTAC on the monitor, or you identify a new rhythm, go ahead and check for a pulse very quickly. If there's no pulse, or if there's a question whether you feel a pulse, you don't feel a pulse, any of that, get right back to chest compressions, because that's what's important. If there is a pulse, you're going to move to the appropriate post-arrest algorithm or the new rhythm algorithm. Of course, if the rhythm is VFib or VTAC, then you're going to go ahead and shock because you've already charged. Whereas if you didn't already charge, you'd have to resume CPR while charging the defibrillator, clear again, and shock. So getting that perishock pause down to one single pause during your switch of compressors is super important and really optimizing patient care. And again, we want to emphasize the switch and make it mandatory at the 2 minutes because rescuer fatigue is real, and most rescuers aren't going to tell you they're fatigued, unfortunately. And they might not feel fatigued, but their compressions will become lackluster eventually. And it's best to just switch during that pause because you have to pause at that point anyways to analyze the rhythm. So switch your rescuers and start with someone fresh. It's going to maximize the number of compressions delivered per minute. Interruptions should not exceed 10 seconds. So keep your perishock pause below 10 seconds. Of course, you want to establish vascular access using normal saline. If you're unable to establish IV access, then establish IO access using an adult IO, especially the easy IO makes it very easy. Hence the name, I suppose. With our humeral head IOs, you really have super fast infusion rates. Vascular access should be achieved without interrupting chest compression, so don't tell somebody to stop so you can get a line. As soon as the IV or IO access has been established, administer your epinephrine. You want to do epi early. And the current guideline for epinephrine for the national standard is 1 milligram of that 1 to 10,000 epinephrine administered IV or IO, and you're going to repeat that every 3 to 5 minutes until a pulse returns. Now, this may change, and your local guidelines may be different than this. However, this is still the AHA standard. So your 1 milligram of epi every 3 to 5 minutes is the AHA standard, and there's no max dose. You keep giving epi until you cease resuscitation efforts. Whenever you give medication through a peripheral IV during CPR, follow it immediately with a 20 milliliter flush of normal saline IV, and then elevate the extremity for 1 to 2 minutes to facilitate delivery of the medication to the central circulation. You want maximum distribution throughout the body of the medication. Now, you may not see this done a lot in the field, and part of the reason is you have a bag running wide open, and that's kind of your flush. You could lift the arm to facilitate, that gravity to get the medication moving, and keep that in mind that is the expectation. Several options are available for airway management when it comes to the cardiac arrest victim. A BVM may be used throughout the resuscitation effort. However, mechanical ventilators provide a very specific diagnosed rate and depth, and that might be better than a BVM because hyperventilation is not a great thing when you're working a cardiac arrest patient. In fact, it can cause adverse outcomes. All right, and then for adults in cardiac arrest without an advanced airway, you're going to want to remember to use that 30 to 2 compression to ventilation ratio. So for every 30 compressions, you have to stop and provide the 2 ventilations. And that truly is the advantage of getting an advanced airway, is because then you can provide your asynchronous compressions and ventilations and not have to worry about stopping every 30 compressions to provide those ventilations. And we know from what we just talked about that compressions are key, and minimizing interruptions in those compressions for good cerebral perfusion is truly advantageous for the patient. Ventilate with just enough volume to produce viable chest rise and deliver each breath about 1 second and allow 2 seconds for exhalation. If the decision is made to insert an advanced airway, then verify placement by multiple methods, but you have to use waveform capnography to truly confirm that device is in the right place. Not to mention, waveform capnography provides tons of advantages when working a cardiac arrest patient, and including allowing you to know if you're providing good CPR. And then you're going to want to make sure you provide at least 1 breath every 6 seconds. I say at least, but it's 1 breath every 6 seconds, about 10 breaths per minute, without interrupting chest compressions once you have that advanced airway in place. Your fib or your pulseless VTAC that persists or recurs after 1 or more shocks, that's called refractory VFib. or refractory VTAC. An antidysrhythmic such as amiodarone may be considered, and it says considered, but in the algorithm you're going to be giving it. After your second shock, you'll give 300 of amiodarone. After about 5 minutes, you'll give another 150. Now, the American Heart Association does recognize lidocaine as an equivalent to amiodarone. It's coming back into favor, so you could really use those interchangeably, amiodarone or lidocaine. And I believe lidocaine is 1 to 1.5 milligrams per kilogram fast IV push for the arrested patient. But getting back to this refractory VFib patient, this is what they're really trying to solve, what they're trying to figure out. Some of the things that they've talked about doing for this patient, because the refractory VFib patient is the patient that has a chance of surviving. That VFib rhythm is typically a fresh kill rhythm, meaning it's a relatively recent death. So this patient isn't that far gone generally to where they can't be resuscitated. However, if you don't terminate that rhythm, they won't be resuscitated. So one of the things that they mentioned to do pre-hospitally is to move the pads, so your anterior-posterior placement before providing your next shock. That is shown to be effective. They've also used 2 defibrillators and providing double sequential defibrillation, where they would shock and then shock immediately following that. That's the sequence, and they found some benefit in that with terminating refractory VFib. Unfortunately, several monitors can become damaged by doing that inappropriately. They also do something called ECMO. ECMO is ECMO, which is extracorporeal membrane oxygenation. It's basically a bypass where they get a venous line and an arterial line, and they take the blood out, they oxygenate it exteriorly, and then put it back into the body. And they can basically have a chemical code. They don't need to provide chest compressions during that, and they can catheterize the patient while they're on ECMO. This is super advanced and usually only done in your academic institutions, your big teaching hospitals, because it's very expensive, and unfortunately, hospital systems are based primarily off of medical insurance reimbursement, and the cardiac arrest patient often doesn't pay their bills, right? So they don't really see the advantage in the money in it, and that's unfortunate because it really is some great advancement in cardiac arrest care to see the ECMO during a cardiac catheterization. It's really progressive. Of course, you've heard of the H's and the T's, and these are the reversible causes of death, or the possibly reversible causes of death. You're going to want to make sure you go through your H's and T's and treat any reversible causes. If there is a ROSC, or return of spontaneous circulation, assess the vital signs, support the airway and breathing, and give medications as indicated. Treat the ROSC patient, like this very, volatile being that could go at any moment. And it's all up to you to keep them where they are, as in pulse producing. So prepare your epi-drip or your pressor. Don't allow their heart rate to get back down to where it was before they bottom out and zero out. Don't allow them to lose a blood pressure and eventually lose their pulse. Make sure you get a 12 EDKG. Transport this patient. If it was a medical cardiac arrest and it's now a post-arrest, transport them somewhere where they can get PCI, meaning your STEMI centers, right? Because you want these patients to live. Typically, your post-arrest patient getting cardiac catheterization is one of the best things that can happen for them. I think there's nothing else done on a ROSC patient that provides as much survivability or post-arrest to walking out of the hospital neurologically intact than cardiac catheterization. So you want to give those medications as indicated for regulation of the heart rate, controlling dysrhythmias, and maintaining blood pressure. Super important. Here are those H's and T's that we talked about. Of course, you're familiar with them. Hypovolemia, that's an easy one. Want to give fluids. We don't have blood, so if they are bleeding out, you want to, and this is like a post-arrest patient, let's say, you want to provide permissive hypotension. You don't want to dilute their blood too much. However, while they're in arrest, you're going to be providing rapid fluid infusions. Hypoxemia, we correct that through ventilation and oxygenation. Hypothermia, we correct that with a blanket. Hypokalemia can both be treated, but not necessarily pre-hospitally. Pre-hospitally, really all we have is fluids for the most part. Now, the hyperkalemic patient could get treated with calcium chloride or calcium gluconate in some instances. You're certainly not going to give potassium for the hypokalemic patient pre-hospitally. The hydrogen ion or acidosis. Acidosis is inevitable the longer they're in arrest, and sodium bicarbonate may be indicated. And then to your T's, tension pneumothorax. Tension pneumothorax is a pneumothorax that has become hypoperfused. That's what makes it a tension pneumothorax. So an easy way to remember is hypotension equals tension. It could just be a simple pneumothorax, and that wouldn't be a tension pneumothorax. This is somebody that has tracheal deviation, has JVD, has poor perfusion, and in this case, they're in cardiac arrest. So assess for that, especially if trauma, but there could be a spontaneous pneumo. So assess for lung sounds and provide needle chest thoracotomy as needed. Cardiac tamponade. Cardiac tamponade typically is going to be present due to blunt force chest trauma. On an EKG, it could show you something called electrical alternans, which change colors here. Electrical alternans are kind of little, big. Well, that's horrible looking. Let me do that again. Little, big, little, big. They alternate. The QRS size alternates from small to large, small to large. A cardiac tamponade also presents with what's called Beck's triad, which is your muffled heart tones, your hypotension. In this case, they'd have a blood pressure at 0. And JVD indicating that blood's not able to fill the heart. So the treatment pre-hospitally would be a pericardiocentesis, which is a large cardiac needle. You're going to enter in substernal, just below the xiphoid process, on the left side at a 45-degree angle off the chest, and you're going to aspirate as you advance that needle towards the heart, which is at the midclavicular line. And once you start getting blood, you're going to draw back as much blood as you can, about a 60 cc syringe, and then reassess the patient, do it again as needed. Very, very uncommon procedure. Moving down your T's, toxins, so drug overdose is another possibility, thrombosis, which covers massive MI and pulmonary embolism. So all of your VFib arrests, you should think it's an MI until proven otherwise, right? And pulmonary embolism is a horrible one because if they arrested from a PE, like a big saddle PE, chances of them ever coming back is slim to none. They do at some hospitals provide thrombolytics intra-arrest, but you got to think you're doing chest compressions on this patient. How much trauma are you causing? And then thrombolizing them could cause some significant bleeding. So even if you clear out the blood clot, you could be causing a hypovolemia. And that covers the H's and the T's. So when do you transport these patients? Obviously, you're going to follow your local guidelines. However, if the patient regains a pulse, if you have a ROSC patient, you're probably going to want to transport them. But that doesn't mean if you're working a cardiac arrest, you get a pulse back, immediately jump in the truck with that patient and get going to the hospital. Because like I said before, you kind of have to baby this patient and be ready to manage them because their condition is volatile. And so that means you want to have your control measures in place. You don't want to reverse everything you did by trying to rush getting him into the truck and losing the airway, losing your venous access or your vascular access, and detaching the monitor and all of these things. Move in an organized and systematic fashion. Be fast, but as fast as you can be while maintaining a nice, controlled, organized fashion. And get your pressor drip ready. Get everything ready to go before you move the patient. Get a good set of vital signs. Transmit your 12 EKG before you start driving. All of these things are going to give you kind of that time out to make sure that you're not going to undo everything that you've done thus far. Of course, not every cardiac arrest is the same. In fact, no two cardiac arrests are the same. And there could be special circumstances that are even more outside the norm. Cardiac arrests that require the paramedic to adjust treatments and procedures include the following. Morbid obesity. You might not be able to provide good chest compressions on the morbidly obese patient. Might be harder to have a successful defibrillation because of all the extra tissue. Also, your anaphylaxis patient. they may require epinephrine early on. Anaphylaxis patient might require an airway early on. Your opioid patient, again, you're going to want to make sure that you're looking out for any needles or syringes or anything like that. Your acute asthma patient may require more aggressive airway management than your sudden cardiac arrest victim. Your acute asthma patient is likely severely hypoxic, and you wouldn't want to do compression-only CPR on them because that patient has no oxygen reserves. And then your electrolyte disturbance patient, unfortunately, there's not much you could do in many systems for the electrolyte disturbances, such as hyperkalemia. And you're probably not going to get the hyperkalemic patient back without getting them some calcium chloride. So that is unfortunate, but those are your special circumstances. All right, so post-cardiac arrest care. You're going to begin by optimizing oxygenation and ventilation. You want to try to achieve greater than 94% on your pulse oximetry, and make sure you're obtaining pulse oximetry the entire time. Avoid hyperventilation, though, because that can cause decrease or decline in cerebral perfusion, and you don't want to do that. You want to obtain a 12 lead EKG as soon as possible and transmit that 12 lead EKG because a lot of these patients will require percutaneous intervention post-arrest. Perform a neurologic assessment. Assess for signs of hypoperfusion. These things are going to, if they are hypoperfused, you're going to want to make sure you're maintaining good blood pressure. Your neurologic assessment is going to help you to have a better idea on whether this patient needs to be put down and intubated. And actually, it's a good sign if they're showing some sort of neurological improvement. Administer a fluid bolus of 1 to 2 liters, normal saline or lactated Ringer solution as needed. And then if the patient has marked hypotension and the transport time to the medical facility will be prolonged, you're going to want to consider administering a vasopressor infusion and start that sooner than later, because these patients will decline rapidly, especially if they're bradycardic. If their heart rate starts to decline, you want to have an epinephrine infusion or dopamine infusion or something like Levophed, norepinephrine going before they bottom out. And epinephrine is perfect because you've likely administered epinephrine while they were still in arrest, and they're metabolizing it. It's wearing off. That's why they're starting to become bradycardic. So be ready to treat that bradycardia. And treat tachycardia with the tachycardia algorithm as needed as well. You don't want to start targeted temperature management. They're going to do that at the hospital most likely. We used to do it pre-hospitally a lot. These are for the comatose patients after ROSC. And basically all they're doing now is they're maintaining a slightly hypothermic state, which actually slows down cellular death within the brain. And involves maintaining a constant target body temperature. It's about 32 degrees Celsius and between 32 and 38 degrees Celsius for at least 24 hours. Rapid infusion of cold IV fluids is how they used to do it, but that's not how they do it anymore. We used to give a large 2 liters of cold saline and rapidly decrease their heart rate, rapidly decrease their temperature, but that's not really what we do anymore. They actually do cold blankets and things like that now. And they're going to closely monitor the post-cardiac arrest patient. The American Heart Association recommends that rescuers who begin CPR continue until one of the following occurs. You could have effective spontaneous circulation. That would be your ROSC patient, right? When the care is transferred to a team providing ALS, so from your BLS providers to your ALS providers, then ALS providers will take over. The rescuer is unable to continue because of exhaustion, because of environmental hazards, or because continuing the resuscitative efforts places others in jeopardy. So obviously safety and health come first. Criteria indicating irreversible death have been met. Criteria of obvious death have been identified, or criteria for terminating resuscitative efforts have been met. So all of those. So typically your criteria for termination is a prolonged resuscitative effort, or the presence of a really low capnography under 10 millimeters of mercury, the presence of rigor mortis, the presence of liver mortis. Any of those things would indicate that you could stop your resuscitation effort. When the patient does not respond to pre-hospital cardiac arrest treatment, it is acceptable to cease efforts because the following. You got ALS providers are capable of performing an initial resuscitation equivalent to an in-hospital resuscitation attempt. There are no additional benefits to ED resuscitation. So when you're outside of those systems that provide ECMO and advanced therapies, typically you know that pre-hospital you're going to do everything that the hospital would do for a cardiac arrest patient. CPR performed during patient packaging and transport is much less effective than CPR administered at the scene. That's why we don't really like to transport patients until we achieve ROSC. However, there could be circumstances, for instance, if you're in a public place, you're going to transport that patient. And it's not because it's providing any advantage to the patient, but it could be providing advantages to bystanders and businesses and so on and so forth. EMS providers risk physical injury while attempting to perform CPR in a moving ambulance while unrestrained as well, and that's something to consider because we don't want to put EMS providers at risk performing, lackluster CPR anyway. We know that CPR is not that effective. Why put somebody at risk to do it? So again, transporting an intra-arrest patient is not ideal. Continuing resuscitation in futile circumstances cases it places other motorists and pedestrians at risk, increases the amount of time during which the EMS crew is unavailable for calls, and impedes the care in the ER of other patients, and it also incurs unnecessary charges from the medical facility. So several reasons why you shouldn't transport a cardiac arrest patient that's futile. It's a futile case. There's no survivability. That patient should not be transported. The American Heart Association has published criteria for BLS and ALS termination of resuscitation for the adult out-of-hospital cardiac arrest patient. However, local guidelines will, overpower those, so to speak. In some jurisdictions, state legislation will require the permit pronouncement of death at the scene by the paramedic, okay? And then gaining permission to stop CPR in the field will involve delicate issues such as expectations of the patient's family, disposition of the body, the pressure from bystanders. If people on scene are pressuring you to work somebody and maybe the scene's becoming unsafe, go ahead and transport that cardiac arrest patient. Paramedics unaccustomed to telling family a patient is dead could also have a situation. So if you're not that great with people, you're going to have a hard time here. You got to, do things like take off your gloves, make sure they saw the resuscitation effort, make sure you're showing empathy and compassion. Know that anger is one of the normal responses to losing a loved one. And they might punch a wall or yell loudly. That's normal. That's healthy. And provide them with help as needed. Contacting funeral services, contacting loved ones. When the medical examiner releases the body, you can make it more presentable if that's the case. All of these things, again, none of them are universal. None of them work in every circumstance, and you may end up transporting. Even though I give you plenty of reasons why you wouldn't want to transport a cardiac arrest patient, there are outside-the-box circumstances, your gray areas, and then there are protocols that may require you to transport the futile cardiac arrest patient. So again, there's no universal truth here. You kind of have to, go call by call. So with that, we've reached the end of this video on cardiovascular emergencies. And we really kind of touched the outer surface of the cardiac arrest response. This is covered much more in depth in your advanced cardiac life support training that you're going to be receiving.